Hello. Today we are going to talk about ECGs that you cannot afford to miss if you're working in the clinic or in primary care. And we are not talking rare curiosities, we're not going deep into cardiology trivia, but we're going to recognize where we need to identify early changes or outcomes and why missing them can cause harm. So my aim isn't to make you faster at naming patterns today. Today is about safety. It's about helping you to decide what matters. So I did a little survey in primary care, and I noticed that, most people, at least 70% of people, wanted help with recognizing life-threatening ECGs. We're already shielded by guidelines. So when a patient comes in with obvious symptoms and maybe an ECG that just looks off, many times we send them to the hospital. But there are some times when the patient is not very symptomatic or doesn't want to go to the hospital. So we need to know. I realized that most people wanted to know how to recognize the life-threatening ECGs, and many people, most or more than half of people in primary care interpret ECGs weekly, and also more than half of the people in primary care, they worry about under-referring or over-referring. The most requested topics were to talk about dangerous ECGs, common referral mistakes, bradycardias, and AV blocks. So, in the next few minutes, might not be up to 30 minutes, what we will cover is we are going to cover why ECG interpretation remains a high-risk task in primary care. We're going to discuss a simple framework that you can use to make safer decisions with ECGs. We'll just chat through 5 ECGs you cannot afford to miss in everyday practice, common ECG mistakes that lead to over and under referrals, when to escalate, when to reassure, and when to pause, right? Why do ECGs go wrong in primary care? Because we are often time constrained. We already have a lot of tasks, a lot of patients we are seeing, and we don't have immediate specialist backup. Before you try and reach somebody in the hospital, it takes a very long time. Talk less of sending them the ECG pictures, and these ECGs can sometimes not be black and white. They are not clearly normal or clearly abnormal, and we need to make quick decisions because others are depending on us to go through with a plan. And the common failure points are that when because we need to move forward, prioritize so many things to do, we give false reassurances from just looking okay, or delay when uncertainty isn't resolved, or we see benign patterns that we do not know are benign. They just look like, ST changes, T wave changes, and then we over-escalate. Also, there's this danger of subtle changes that are missed or underestimated. Now, if you're in the UK, there are a lot of guidelines that are in place, especially when you have chest symptoms. For example, when you have acute coronary syndromes in adults, there's the NICE NG 185. There's also guidelines on transient loss of consciousness or blackouts. One of the first key tests you have to do in that regard is a 12-lead ECG. Also, when we are talking about irregular heartbeats, if a patient comes in with palpitations, one of the first things you have to do is an ECG. If they've had chest pain of recent onset, we are very well covered by guidelines in this sense. We know when there's chest pain within the last 72 hours. We know the referral guidelines for referring to the rapid access chest pain clinic. But sometimes your patient insists that nothing will take them to the hospital. Or sometimes they say the chest pain has resolved and it's really outside the timeline that the guideline has provided for us. Also, there are some syndromes like Welling syndrome that would the patient will be asymptomatic, but they're having significant occlusion of their coronary arteries. So also, we talk about ECGs. When we talk about national guidances, we know we have the advanced life support algorithms, and it's just essential that if a patient has an ECG that is within these algorithms, we know to send them to emergency, or at least give them some advanced life support. But these are the national guidances that generally cover ECGs that we know about. But national guidance is not enough on its own because, as we know, as general practitioners to be, or or as people working in primary care, even if you're an hospitalist and you're working in an urgent care center where there are few there are fewer opportunities to do bloods and investigations. We know that there are gray areas. Sometimes these ECGs are not black or white; they can be borderline, and we still need to decide what to be able to do immediately. So we're just going to do a little recap of the foundations. When we talk about ECGs, as you will later see, sometimes you're worried about, can we send this patient to the hospital now, soon, or later? But I just brought up this diagram of the heart. Here we can see that we can remember that the impulses are generated from the sinoatrial node, which is located in the right atrium, and through internodal pathways they go into the atrioventricular node. From the atrioventricular node, we know that we have bundle branches into the left bundle branch and the right bundle branch. As the left bundle branch branches off, it goes into the left anterior fascicle and the left posterior fascicle. We know that this, I do not really want to go into details, but we know that when there's a conduction problems at any of these stages, either with the sinoatrial node, in which case you might have sick sinus syndrome, atrioventricular node, you're talking about your atrioventricular blocks, your left anterior fascicular blocks, where the anterior fascicle is blocked in addition to your right bundle branch, your trifascicular blocks. When any of these are affected, it does show up on the ECG, but this is just to give us a quick reminder. And if you want more information, please go to our YouTube videos, our website. We break down the basics of ECG for people who just want that foundational knowledge back. We know this is the P wave, is the first positive deflection. The first negative deflection is your Q wave. The first long positive deflection, the next long positive deflection is your R wave, and then the next negative deflection is your S wave. So the transmission of impulses across the right atrium to the AV node is where you have your PR interval. Your QRS represents ventricular depolarization. Your T wave represents ventricular repolarization. And sometimes you have other waves like your U wave and the J waves, which we will not elaborate on today. We remember how we map out injury, chest injury. We know when it's in your 2, 3, and AVF, you're talking about an inferior MI. When it's going on in your V1 to V4, you're talking about anteroseptal MI. Your lateral leads are your V5, V6, 1, and AVL. AVL is always the forgotten lead. Never forget your AVL. And also you look at your AVR. Remember that, for example, especially for those of you who are actually putting on the leads of the ECG yourselves, remember that sometimes I know if you're used to this, you will rarely make mistakes, but sometimes the ECG might look abnormal because the leads are placed wrongly. But as a rule of thumb, AVR is always negative. Lead 1 is always positive. Now, what is the simple framework that I teach in my course, or I just teach across board? It's called the RAIC system, the rate, rhythm, regularity, axis, intervals. Now, my I stands for both intervals and injury, and I'm looking at the structure, the complexes. I'm looking at the intervals. What's the PR interval? What's the QT or the QTC? Is there a U wave? Is there a bundle branch block? So injury, the markers of injuries would reflect in whether, for example, the most obvious ones, the ST elevations, the T wave inversions, the QRS complexes, especially if you're looking at your bundle branch blocks, the William-Marrow system. Then I always say that context is king. Because even if you have a normal ECG, if you follow this step and you have a normal ECG, you still need to check, how is my patient? If your patient is in active chest pain, or they have just come out of or they are symptomatic, and normal ECG does not rule out anything, maybe you need serial ECGs, maybe you need urgent bloods, right? So the safer way to use ECGs is, are you talking about now, soon, or not today? So for this ECG, I'll just quickly go through it using my system. I'm aware that we have just a fixed period of time for this. So for example, roughly I can tell you that this is a sinus reading because there's a P wave following every QRS. It is regular across board, especially in my limb lead, in my rhythm strip. There is the PR interval looks normal across board. Your PR interval should not be more than 5 small boxes. It's about 5 to 6. If it's greater than 5 small boxes, you're suspecting what? And it's across board, you're suspecting a first degree AV block. But here it looks quite normal across board. Yes, I can confirm that. Then my QT interval does look fine as well. In terms of rate, because if you go sequentially, regular, rhythm, we've said this is a sinus rhythm, rate, you just count. If it's regular, you can just use your 300 over the normal number of big small boxes. That's 1, 2, 3, 4, 4.3. So yeah, it's roughly going to be in the 70s, between 70 and 80 beats per minute. And also, I'm now looking at my I'm looking at my intervals. I've talked about intervals, the injuries. Are there any markers of injury? So I'm looking at, there any ST elevations? Are there any bundle branch blocks in my V1, V5? It does look like there is some ST elevation in V2, about 1 or 2 small boxes, and in which case what I quickly do is I map my ECG into quadrants. So I discussed this at length about how you can map your ECG into the region. So you map out, there's a theory I teach about the inverted L's. I'll see if I can quickly annotate here. So 2, 3, AVF is the first L, V1, V4 is my second L, 1 is my next square, AVR is my next square, V5 to V6. So this is the lateral aspect. This forms the anteroseptal. This is lateral, this is inferior. With this, I can tell you where my S elevation is occurring. My S elevation seems to be occurring in my V2, V3, V4. Now, you have to know your basics. For example, in men above 40, even an S elevation of more than 1.5 millimeter is significant. So I'm going to be asking, how is my patient? Where is my patient? Context means, what is going on with my patient right now? Or do I have previous ECGs to compare with? So that being said, we're going to move on. Now, what moves an ECG into now? If they have ischemic changes on the ECG, if they are symptomatic and there's an abnormal ECG, and if the ECG is just not making sense, or the context is not making sense, the ECG looks normal and the patient is sweaty, clammy, or the ECG looks abnormal, like a ventricular fibrillation kind of a thing, but the patient is alive. Ventricular fibrillation is not compatible with life. So you're asking yourself, is this an artifact? You repeat the ECG is the same thing, or you're seeing new changes you've not seen before. That moves an ECG into now. And I brought up this very beautiful infographic for you. There are 4 broad categories, so to speak, that an ECG will fall into, right? Immediate risk, right? Now, or stroke, sudden cardiac death. A patient or a young patient may be fine. Maybe they came in for an incidental ECG, but you find features of Wolff-Parkinson-White. You find features of Brugada. You find high risks inherited or structural patterns, or malignant arrhythmias, or high-grade conduction problems. Do not be falsely reassured, right? You need urgent cardiology advice. Sometimes is the heart beating or conducting abnormally? Is it too slow, too fast, irregular, blocked? Now, so many of these are not now problems, right? But many of these are not now problems. For example, if it is too slow, there are benign variants of when it is too slow and benign variants of when it is too fast. However, you should be able to identify your blocks. Identify, is this a complete heart block? Is this a first degree heart block? Is this a second degree Mobit 1 or Mobit 2? First degree heart block many times is asymptomatic and there's nothing to do. Second degree Mobit 1, you might get away with it depending on the context. Second degree Mobit 2, most likely might need some intervention. Complete heart block will always need intervention. And then you need to talk about, do they need pacing or do they not need pacing? Now, also, you need to know your ischemic changes. You need to talk about metabolic. Yes, this is very important. Sometimes the first clue that you have about maybe hypocalcemia or hypercalcemia or hyperkalemia comes from your ECG. And in that case, once you see an ECG, you want to go back to their blood. You want to maybe call the patient, maybe to go to the emergency department or come to the surgery for repeat bloods. Now, this is another beautiful infographic, how to think about any ECG. So step 1, if you used your VAIC method, which I've said, or your own personal method, you want to ask yourself, does this ECG look normal or abnormal? Now, a normal ECG has sinus rhythm, normal rates and intervals, no ST changes, no normal complexes. An abnormal ECG, before you interpret it, you have to classify. Is it a variant or a true abnormality? For example, if you have a young patient completely asymptomatic, maybe had a routine ECG for normal findings or for normal things, and then you're seeing symptoms, you're seeing an ECG with concave ST elevation and with no reciprocal changes, they are not in contiguous leads when you use my L stroke inverted L methods, then it might just be benign early repolarization. But never be very cautious of diagnosing benign early repolarization in patients above 50, right? So ask yourself, is this a normal variant? Athletes we know can have some sinus bradycardia. We know that sometimes when the beats are irregular, but there's a P wave followed by a QRS and it is sinus, it can just be sinus arrhythmia, right? So the step 3 is, if it is truly abnormal, the 4 groups we've discussed. Is it a conduction problem? Is it an ischemic problem? Is it a structural or sudden death risk? Or is it a metabolic problem? Now, the bottom line is, do not interpret first. Context matters, right? So let's talk about these ECG cases. We have these ECG cases, inferior STEMI plus or minus RV infarction. Now, I think I will stop this here and continue to reduce the risk. When I come back in the next video, we're going to be really dissecting these cases, because I think these cases are very important so that we don't skim over them, right? We have 4-5 common cases to discuss and why these are important for you to know, even when you're not in the emergency department.